Hello, everyone. My name is LJ Stambuk. I'm the President and CEO of the World Affairs Council of Charlotte. I'm delighted to have with us today Dr. David Callaway. He's the Emergency Medical Director at Atrium Health CMC-Main, and he's also on the World Affairs Council Board of Directors. Dr. Callaway, 6 months ago, think about it, had the presentation on COVID-19 and what we're doing in the community and what measures we're taking and what does it all mean. We're back 6 months later to look at the COVID global pandemic in Charlotte and the region once again. As the community's premier global education nonprofit, nonpartisan organization, the World Affairs Council of Charlotte has always sought to bring the world closer to you, our members and supporters, and to build a community of internationally informed and engaged citizens. Dialogue, knowledge, active participation in an understanding of global issues are vitally important for our democracy to flourish at all levels. We would like to thank Atrium Health. Thank you. Thank you for being a corporate partner with the World Affairs Council. Thank you for your support. We'd also like to thank the students joining us today from Davidson College, UNC Charlotte, Queen's University, and Wake Forest University. Now, before I go into the details of the program and how we're going to do this, I would just like to give a shout out, as they say, a big thank you to the World Affairs Council board members with us today and to the World Affairs Council former board members that are with us today. Thank you for your leadership. Thank you for all you're doing. And together, the board and the staff will do everything to sustain the World Affairs Council and continue our important role in the community. So, a couple of details. Your microphone will be on mute and your camera turned off for the duration of the presentation. To submit a question at any time, and we do want to have as many of your questions to Dr. Callaway, please use the Q&A box circled in red in the Zoom toolbar. Do not use the chat box. Use the question and answer box if you want to put your question forward. And then finally, please do know that this presentation will be recorded and will be shared out via the World Affairs Council mailing list. So please make sure, if you're not a member, that you're signed up with your correct email address and that you can receive the World Affairs Council emails, because we will send you the recording of today's program. If you enjoyed this free program, please make a tax-deductible donation to help support the World Affairs Council's International Education Mission. There's a button, you can follow it on our website. Or if you're by any chance not a member, please do become a member and support the World Affairs Council of Charlotte. Thank you. We are on social media and you can follow us there as well. All the previous programs of the World Affairs Council, and we had nearly 95 since March, are on YouTube, and you can follow them and see all the speakers. We had very interesting speakers over these past 6-7 months. Dr. David Callaway, and I have to say this doesn't need an introduction. He is an amazing fellow and someone that all of you should get to know better. We're fortunate to have him move to Charlotte, and in the meantime, he is a professor of emergency medicine at Atrium Health in Charlotte, where he's also the chief of disaster medicine in the Department of Emergency Medicine. Dr. Callaway is a Navy veteran who served with the United States Marine Corps in Iraq, Burma, and El Salvador. He's the father of Elizabeth Liliana, two princess warriors, and husband of Dr. Jennifer Callaway. David has an unrelenting drive to improve his community and a healthy state for the status quo. Dr. Callaway subscribes to the idea that crisis offers opportunity. As an Eisenhower Fellow in 2014, Dave investigated the health and security impacts of Syrian refugees on Jordanian civil society. Currently, he's working to mobilize U.S. combat veterans to engage in community service projects focused on social justice. David's extensive work in health and crisis management recently led to his appointment as Chief Medical Officer for Team Rubicon and a life member of the Council on Foreign Relations. Currently, Dr. Callaway leads the Emergency Medicine COVID-19 Nerve Center and is involved in Atrium's health crisis surge capacity planning. We're fortunate to have Dr. Callaway on the board of the World Affairs Council of Charlotte, and I will turn it to you now, Dave. Please go ahead.
Thanks, LJ, for the introduction, and thanks again for the amazing work that the World Affairs Council of Charlotte is doing, and really a tribute to the leadership to be able to pivot so quickly in these times. So, LJ, can you just let me know that you're seeing the screen?
Yes, we are.
Great. So 6 months in, hard to believe. Let me just give a disclaimer, which apparently doesn't really mean much, but I'm going to talk from my perspective, and these views don't necessarily represent Atrium Health, the Council on Foreign Relations, Team Rubicon, certainly not my wife, and definitely not my daughters. But what my lens is in this crisis is shaped by all of those. And so I want to go through a few things. Generally, I don't like doing PowerPoint, so I'm going to try to go quickly so that we can mostly have a conversation. But there will be some critiques in here, and I think that should set the stage for what we talk about. So here's how we're going to roll through this: a situation update, some COVID response. Then I want to talk about some real life stuff, because these are the questions that I'm getting all the time. What should we do for Halloween, Thanksgiving, voting? What's on the news? I want to talk a little bit about challenges, and mostly to set that up for the conversation, because I think there's.
Dave, sorry to interrupt, but it looks like you might be sharing a different screen. We're seeing your notes view and not the presentation view.
Yeah, let's just do that then. Great. How's that?
Perfect.
Is that better?
Mm-hmm.
Awesome. Okay. All right. So situation. I think everyone on here is probably tracking this, but I just want to level set a little bit. So 41 million global cases, over a million deaths. The U.S. is again a hot spot. Travel outside of the U.S. is pretty limited. The Canadians opted this week to continue to keep the border closed. Mexico, thankfully, very kindly has kept the border open. So it's having an impact dramatically globally. And the next series of graphs I'm going to show you come from the New York Times, because frankly, I think they put together the data in one of the most visually interesting and informative ways. So in the US, what we're seeing is what's being called this third peak. And if you see in the last 14 days, we've had about a 36% increase in cases, and we're starting to see a slow tick up in the number of deaths. And I'll just tell you that the death rate had been decreasing or had been stable for the last several weeks. And what you can see on the heat map of the US is we're starting to see these other pockets emerge, and you all have probably been reading about what's going on in Wisconsin, or at least seen it on the news. And I bring up Wisconsin because it is a very good example of how we're not out of this yet. Wisconsin just opened a field hospital. Now I remember when this was the thing in the US, and we were doing this in March, April, May in New York and California, and we had plans in Charlotte. And I thought we were done with that. I mean, this idea that 6 months later we would actually be setting up a field hospital again, was baffling. Now I thought we might need to do it come December and come flu season, but not in October. And so it's a concerning trend. And what we've also seen as a trend is initially COVID was bad in urban areas, and that makes sense because tightly packed, crowded spaces, more people. But now it's really becoming more of a rural, we're seeing a significant spike in rural areas that were previously somewhat protected just because physical distancing and individual volume per square mile was lower. But we're seeing this increased uptick, and that's important because the rural areas in our country are historically underserviced by healthcare and by things like broadband, internet, and some of the other services that have really been leveraged in an innovative way to help drop these spikes. So they're at a significant disadvantage as we start to see these cases go up, and we're also seeing deaths go up, in rural areas more than urban areas. So what about North Carolina? I think everyone saw the news, but we are also, again, starting to see more cases. Our death rate is flat or negative, which is great. But you'll notice that bottom number, the hospitalization rate, is going up. And I'll tell you that hospitals across the state are full. And they're full of non-COVID patients, and probably the rate of COVID patients varies between 10 and 20%, somewhere around there. But the amount of work it takes to care for a COVID patient, the amount of logistics and the amount of additional energy really is disproportionate and very much destabilizes our ability to provide care for other people. It's a significant challenge, and we've gotten a lot better at it. And I'm going to talk about some of the positives, but this is a big deal as hospitals start to fill back up again, especially since we're not even to flu season yet. So here's, again, New York Times, what you can see is the darker colors are increased rates of disease. So for example, in Charlotte and Mecklenburg County, we have about 18 per 100,000. As comparison, South Korea has about 5 per 100,000 cases. And if you look out at Gaston County, you see about 38 per 100,000. And you can just see, again, the areas like Lumberton and Eastern North Carolina are starting to see these increased rates. And that's important because healthcare assets are more limited in some of these areas. And then here's some of our own internal data, and this has come out from the county. These are the percent positive rates, and so this is important because the things that count are how many tests are you doing in a day, and certainly if you do 1 million tests, you will have a grossly higher number of positives than if you did 10 tests. And so the total positives matter, but so do the percent positives, and the target is less than 5%, and that's established by the WHO and the CDC. And so you can see Mecklenburg here is at 4.9. Some of the data has us at 6%, but you can see in the rural areas like Gaston and Lincoln, you have 10 and 11% positive rates. And this is, again, important because these are areas wherever you have these pockets of increased positivity, that can cause these resurgence. Just like if you're out camping and you don't put out the fire and you have these embers that are still smoldering, they can cause a forest fire long after you're gone. So we've seen this, right? We are not moving out of phase 3. Phase 3 got delayed until November 13th, I think, 13th or 16th. And so that means large venues are still limited to 7%. I think indoor is 25 and outdoor is 50, but you can go to the website and see the restrictions. But this idea that we had a month ago that we're going in the right direction, that we're controlling this, has really started to turn around. And now we're facing this surge. And it's, again, going to have economic, it's going to have educational, it's going to have deep societal impacts beyond the direct impact on healthcare. So that's the situation. Doesn't sound super awesome, but let's talk about some of the good things. So this is very self-serving. The next few slides are about Atrium Health and some of the work that Atrium Health has done. So one that I'm particularly proud of, and Lois England, who's the moderator, has been a leader in this initiative, is the Million Mask Initiative. And in my mind, this highlights how you beat a networked problem like a pandemic. So we know that the impact of COVID is beyond the hospitals. And so the only way you can solve this is by bringing together whole of community response to actually address some of the issues that will change the spread of the disease. And so the Million Mask Initiative was curated by Atrium Health, and it was a public-private partnership with 20 of the largest industries in the region, as well as about 20 nonprofits. It was focused on identifying at-risk populations and really just getting masks out to them, and then also helping educate people about why to wear masks. It was guided by science. We had these rapid reevaluation cycles where we're always changing who we're targeting, what type of masks we had, how we're rolling them out. And then frankly, it was accelerated by business. I mean, the fact that the Panthers and the Hornets and Duke Energy and Coca-Cola and Bank of America and Lowe's were all saying the same thing. The YMCA, United Way, the county, everyone was saying the same thing, one message. We need to take action for everyone in our community, and we're all in this together. That is what allowed us to be successful. Because if any one of these organizations tried to do it themselves, they would be more marginalized and less effective. So what did we see? We saw a correlation of more masks we got out, the more messaging we got out. We saw a decreased total number of positives, and we saw decreased percent positive rates. And this is data through August, and we saw this significant decrease. And so what happened? People got tired, and this is a new challenge. It is exhausting to continue to have to think about COVID every single day. And so it's important that we do the simple things right, and we listen to the experts, and then we can actually focus on more complex things. And so more complex things are advanced treatments and vaccines. And so one of the exciting things that I have absolutely zero to do with, because I'm an ER doc and I'm not smart enough to handle some of this stuff, but Atrium Health is the only system in the region that's trialing these 3 new treatments. And one is, they're all focused on pre-hospitalization, so preventing hospitalization or minimizing the consequences of COVID once infected. And then one is also focused on just pure prevention if you've had a high risk exposure. So the first trial is on remdesivir, which is the antiviral you probably have heard much about. And President Trump and Chris Christie and then most of the people in our ICU who get sick get this medication. It's an antiviral. It's thought to have some efficacy. We don't know yet how much, but we have used it for really sick people. We're now in a clinical trial to use it for people who have high risk factors, and we're going to try to see if that'll prevent them from getting sick and ending up in the hospital. And then the other 2 are Regeneron trials, which are these monoclonal antibodies. And you also will have heard of this because this is, again, what President Trump was treated with when he was ill. And this medication is just generally not accessible to anybody in the US. And so the fact that we are one of the trial sites for administering this medication to people within a few days of getting sick or getting exposure is very exciting for our region and our community, but also just for healthcare in North Carolina. So 3 great trials. If you're interested in them, you can go on the website and you can actually figure out how to sign up to be a volunteer in these trials. So that's great. I mean, we're accelerating treatment in dramatic ways, and that's wonderful. What about the vaccine? LJ and the World Affairs Council have done a great job getting speakers on the vaccine development process. And so I'm going to, again, just very quickly go through good, bad, and the ugly. The good is Operation Warp Speed, put together by the administration, has really fundamentally changed how vaccines are developed. And again, I'm not going to, you can go back to Dr. Gambada's presentation, but in essence, it funded parallel development and safety trials so that we were testing and trialing at the same time, which in general cannot be done because it's too expensive. But the way that we've redesigned vaccine trials has been tremendous. And I think we will learn a lot of lessons moving forward. The sort of not so good is that if you look at the Johnson & Johnson and Janssen phase 3 ensemble trial, it's been paused. Eli Lilly's monoclonal antibody trial paused. AstraZeneca paused. It may resume this week, but paused. And then Moderna, which has been in the news a lot, just lost a patent dispute over some of their vaccine technology. Basically had to admit that they stole it from someone else, or they borrowed it from someone else. Sorry. And so what does this mean? I don't know. I mean, the head of Operation Warp Speed says they think they'll have a vaccine that is effective and safe. They'll have the safety data by probably December. And then they think they'll have 100 million doses ready. And I want to believe it, but operationally, I just don't think it's going to happen. So where are we though? All the states have had to submit their vaccine distribution plan last week to the CDC. And so North Carolina submitted theirs, and you can get online and look at the criteria, but 5 sort of standard criteria you would expect: equitable access, inclusive, transparent, data will guide the distribution, will steward the resources, healthcare workers will be first priority, and then high risk individuals like those living in nursing homes. And then they're just general blank placeholders for how it will be distributed, because we don't know the cold chain requirements. We don't know whether it'll be a single dose or double dose. So all of this is going on in the background, and the planning is tremendous, and it needs to be done. However, and again, though this has the president's name on it, this isn't about the president. This is about Americans not trusting vaccines. And prior to COVID, we had some anti-vaxxers gaining some I will call it conspiratorial momentum. And what we've seen because of the intersection of politics and science over the last few months is that the rates of American support for vaccines have basically plummeted. And you can see less than a third of Americans say that they feel comfortable getting the COVID vaccine. And that's like a 23% decline in 4 months. And so this again goes to the challenge of managing a pandemic that requires a whole of government response with strong federal leadership, engagement of the scientific community, the medical community, the business community, the media community. We need to all be on the same page if we're going to beat this. And this is partly why I say to everyone on this call, like it's great, to think about the vaccine. I only think about a vaccine when someone asks me about it, because in terms of a COVID response, it has no operational role for anything that I'm going to do in the next 6 months. Flu shot's different. Everyone should get their flu shot, but the COVID vaccine, frankly, we just need to get people wearing masks, and if we can do that, we'll be in better shape. So real life. All right. So what do we do on our day-to-day basis? So the problem that we tend to have is we overestimate risk, and we underestimate what the cost is. And so risk, this is a good example from the Brits. The Brits always do funny stuff. But risk equals hazard times exposure. So in this particular case, the hazard is COVID, and then exposure is what you do to get exposed to COVID, and that will generate your risk. And inherent in the hazard is what are the things that can make you sicker. So are you older? Do you have multiple comorbidities? Do you live in a congregate setting? All these things that can influence the degree of hazard then affect what your total risk is. Now this is important because I am absolutely horrified of getting eaten by a shark. And I surf, and I have to make a decision about, am I going to go surfing or not, even though I literally get palpitations when I get on my board initially, because I'm scared of getting eaten by a shark. It is exceedingly unlikely, but the consequences are high, and humans are irrational beings. So I bring this up because this is fundamentally one of the problems with how we've responded to COVID is we get so confused by what we should do that we anchor on the left or the right side of the bell curve, and we either say everyone has to wear a mask or no one wears a mask, and you're evil if you are in the other camp. We can't do that. It's a complex problem. We need to think through it. So where it can go? All right, Halloween. So this is how I think about Halloween. And the CDC is going to be our anchor for the next couple slides. So the CDC has guidance on what is safe and what is not safe. So I think about it like this. This is Michael Myers, big scary Halloween. I don't ever want to watch that movie. And so high risk activities. And it makes sense. If you do anything that puts you in close proximity to others for a long period of time, or touching about a bunch of stuff that other people have touched, that is high risk. So trick or treat in a traditional standard way, going from neighborhood house to house, handing out candy from cars, that kind of stuff. Obviously, anytime you put alcohol and drugs involved, it increases the risk. Hay rides or tractor rides with people you're not in your household. Anything you do with people not in your household in close proximity for longer periods of time is high risk. Then there's the Nightmare Before Christmas, not so spooky unless you're me and you don't like cartoons. So moderate risk activities. Now I'm not going to go through all of this. The point is that the CDC lists some of these moderate risk activities, and you can look at it and you can say, hey, look, I have a young, healthy family, and all my neighbors are fine. We use precautions. We believe in the moderate risk approach. Or you can say, I want my kids to be able to see their grandparents. And so I'm going to go with a low risk approach. And then this is the old Charlie Brown Great Pumpkin, right? So, all of these anchor on not being around a bunch of other people. So still having fun, because we know it's important to have some normalcy for kids. Doing movie night, going out on family scavenger hunts, doing things where, you're out in your neighborhood, but not around a lot of other people. This kind of stuff is safe and it's common sense. And really, we should be smart enough that we can put these in play. So if you like graphics, here you go. You can go to the website and you can pick out which one of these you want to follow. But this is pretty easy guidance for how you can handle Halloween. And I like this because it just takes the stress away from it. Because everyone's stressed out about, should I go back to school? Should I let my kids trick or treat? Go and trust the experts. Here's some simple guidance, and it makes sense, and you can actually execute. So what about Thanksgiving? This is a little more complex because everyone thinks Thanksgiving is this core American holiday, which it is. But we can't really eat a lot of food around our family in close proximity with our masks on. So hard to mask, hard to physically distance. You definitely do hygiene. So you have to think about who is going to be there and how do you limit the risk factors. And again, the CDC has a low, moderate, and high risk activities, and they all anchor on the same things. limited number of people, limited number of high-risk people, spacing out, and then doing some common sense interventions. And again, you can go to the website and see this. This is the summary though. All right, so COVID is transmitted by both respiratory droplets, so bigger droplets, and aerosol, and they can linger around in the air. And the CDC just yesterday came out and said, we've changed the definition of close contact from 15 minutes concurrent to 15 minutes in a day. All right, and so this has fundamentally changed the risk calculations for school teachers, but you can also think about it when you're thinking about family gatherings. So the key is you don't want this to get in here. All right, that's as easy as it is. You don't want that to get into your mouth and your lungs. So if you have close exposures, if you have longer exposures, if you're not wearing masks, if you have a high risk spreader like kids coming home from college, or if you have individual risk factors like you're with grandma and grandpa who are 70 and have diabetes, then these are things that are going to increase your hazard and increase your risk, and you should try to avoid them. And then the final thing for me is voting. I will just say Mecklenburg County and the community has done a tremendous job of making voting safe, in-person voting. So you have all kinds of other options for absentee and delivery, but in-person voting is safe. I worked at Panther Stadium and went and voted there. You have physical distancing, you have barriers, they have individual pens that they give you so you can do the touch screen. So you're not touching where other people touch. They have cleaning protocols. They have physical distancing marked out so that nobody's getting close together. And yes, I realize the bottom picture is within 6 feet, but we only did it for 30 seconds. We all had masks on, and I thought it was worth it to get these cute kids' faces on presentation, because you can see they're wearing masks and they're out there to make a difference. All right, challenges, and we'll got a couple more minutes. So data and democracy. So people will often look at us and they'll say, look, third spike, hundreds of thousands of dead, totally out of control. And then they say, well, look at China, 34 new cases, totally flat, confirmed cases and deaths. Isn't China better? And what I would say, just as a conversation point for the next discussion, is from a human security and national security standpoint, the same tools that you use to control a virus are the tools that you use to control an idea. And they're the same tools you use to control a population. So we can certainly stop COVID in its tracks if we tracked every single person with electronic devices, if we limited physically their ability to go and interact, if we shut down transportation, and if we penalize people for violating any of these rules. We could use AI to predict where people are going. We could give people citizenship points that they lose if they violate these policies. We could use big data to influence populations or businesses. So all that can be done. The dangerous slippery slope is, are we going to start doing some of that in the US and start eroding some of our democratic principles and our freedoms? So there's much more to it, but I just want to throw that out there. The other piece is, this is exhausting. It is exhausting to remember to wear a mask all the time, to have extra masks in your car, to remember to stay 6 feet apart, to get a call with to ask for a play date, or ask to go to lunch, or ask, what are you doing about school? And to have to go through in your mind all the different variations of how do you reduce risk. Now, I do this for a living. Like, this is what I do. I work in crisis zones, and I'm exhausted. I mean, I am dead tired. And so I think we need to respect everybody else in our community, take a moment to pause and realize everybody is tired. And if we just think about the other a little bit, and we think about what is the right thing to do for the other, that will help us get through some of these hard times. And there's alarm fatigue. So everywhere you go, someone's yelling about something, and then there's leadership arrogance, and this is meant to be a critique of leadership. And I served in the military under a Republican president. This isn't Republican or Democrat. It's not partisan. This is a leadership critique. And my critique is as follows: you need to be true to science and data. and you need to demonstrate leadership, like wearing a mask, following the guidelines of your own government, following the guidelines of your experts. And we as a community need to not be arrogant about where we are in this. And I think what we've seen is we've gotten a little tired, and then we've said, look, we were doing great in July and August. We got this. And so people got lax. And we saw this at church gatherings with this major outbreak with 60 hospitalizations and 4 deaths. We've seen this at small family gatherings are now becoming these little sources of spread. And we've seen it at large gatherings. We need to respect the virus. We need to respect each other. And if we can just agree on doing the simple things right, like wearing a mask, physical distancing, washing our hands, and respecting each other, that will take away so much noise that we can actually focus on the complex things like opening our schools in a smart way, getting businesses going in a smart way, innovating more, and coming together. So what should you do? Easy. Wear a mask. Act with love. Wear a mask. All the time you're outside, when you're around other people, wear a mask. Physical distance, but don't social distance. Be creative. There's nothing that says that you can't see your friends and family. Just be smart. Be more than 6 feet away. Wear a mask. Do things in a wise way. Do the simple stuff well. Get your flu shot. Get your flu shot. Get your flu shot. And then check out a social media, because I can tell you right now that if you want to survive this pandemic, there's not a lot on social media right now that's going to change anything. Wear a mask, physically distance, get your flu shot, and you'll be fine. There's a vaccine coming at some point. Great. Unless you are going to be the vaccine developer, I wouldn't worry about it right now. Unless you're a researcher developing new treatments, just know that treatments are getting better and we're getting better at caring for people. But you need to wear a mask, physically distance. If you do this, we'll be able to punch COVID in the face. We'll be able to recover. So just a couple quick resources. The Count on Me CLT website is great. CDC website, the North Carolina and MEC.gov websites, and then Atrium has a very good COVID resource center. Novant has a good one as well. Even though I'm speaking just for myself, I still would get a lot of grief if I threw a big purple Novant slide up here. But the health systems, Novant and Atrium, have worked very closely together. There are tremendous resources out there. But again, at the end of the day, do the simple stuff right, and we'll be able to get through this. That's all I've got. So let's chat. I'm excited to take some comments.
Hello, this is LJ Stambrook again. I want to introduce to you Louis J. England, Vice President, Community Engagement and Corporate Responsibility at Atrium Health. Louis, please go ahead and lead our question and answer session.
Thank you. And Dave, I really appreciate all that you've shared today. This was great information for me, and I work in the healthcare system and I learned a lot. We've got a couple of questions, and I would certainly welcome more in the Q&A for anyone that would like to ask questions, but can you explain a little bit more about the 15 minutes of exposure? That was a little bit confusing about now it's 15 minutes over the course of a day.
Yep. Yeah, so this is all about the dose of the virus that you get into your body. All right, so it's total dose. If you get 1 million viruses in your body, that is worse than if you get 10. And so this is the same principle about how masks work, is that if Lois and I are in close proximity and I'm infected and I'm wearing a mask and she's wearing a mask, even though some of the aerosol particles are technically small enough to get through the mask, the sheer number of viruses that come out of my mouth get reduced by my mask. And then the sheer number that go into her mouth get reduced by her mask. So the same principle is if you look at your exposure. So we're reducing the amount of exposure. And what they found is that whether you're in close proximity for 15 minutes straight or if it's 5 minutes, still getting a dose of virus. And so they recommendation to say 15 minutes over the course of a day. Now, 15 versus 17 versus 20, there are a lot of variables depending upon the viral load of the person or not. And so with public policy and public health, this is my opinion, just working in complex operations, you need to take the best science you have and the data you have, make a decision and explain the limitations of why you made that decision, and just say it's 15 minutes because we know 15 minutes is a problem. And we know that they're variables, but we know we abide by this and we do this really well, that's going to reduce our risk dramatically. It may not reduce it to zero, but it's going to reduce it dramatically. And then if you find out as you're watching the impact of that 15-minute decision, if you say, hey, look, it turns out it's actually maybe 5 or 30, then you can adjust the policy. But the key is everyone needs to be on the same page. So federal government, state, local government, because what we see across all of these issues is everyone's got a slightly different answer, and that creates confusion and angst amongst people who are trying to figure out how to do the right things.
Thank you, Dave. And we have a couple of questions about masks. You mentioned the Million Mask Initiative. You've shown pictures of the mask. The question is, how much difference does the type of mask matter?
Yeah, Mike, thanks, man. So it's a good question. Again, I'm going to go back to my big dumb ER doctor framework, right? So anything's better than nothing. So masks do not cause harm. So let me just be clear about that, because the way I think about it, I have the Hippocratic Oath behind me, right? So point number 1 is first do no harm, right? So masks do not do harm. Okay, great. So that is accepted fact. Now the question is, next part of the Hippocratic Oath is do good, basically. So do they do good? So they do variable amounts of good depending upon the fabric, how many layers, and then whether both people are using them. So in general, the better masks have 3 layers, cross-woven, so different angles, cotton or polyurethane, and yeah, from a cloth mask standpoint. And then surgical masks are good, and then N95s are technically respirators, and so they are probably the best, but they should really only be used right now for healthcare workers, or if individuals are going to be around someone who is known positive and they have to be around them. So it matters, but what matters the most is that everybody uses them, because if everybody is using them, it again just decreases the amount of virus that's out there and reduces the overall spread in a community. And if we can get that overall spread down, then that's how this virus will actually get beaten.
That's great. And we have a question also from your perspective. Does Governor Cooper's phase plan adequately address the predicted surge in cases?
I have to think about that for a second to think about how to answer that. I think that there are a couple. So I think there are a couple of components. So the phase plan is really trying to address community spread, and I do think that, again, going back to have a plan, stick to it, and then adjust as needed. I think that it's the right decision right now to stick with phase 3. Some of the components, I'm not sure how they came up with the numbers, and that's my own limitation of knowledge. So I don't know where they came up with 7% for Bank of America Stadium or 7% for larger areas or 50 people outside. You have to pick a number. The number has to make sense in general, and then people have to abide by that. And what I would just say is the problem that we run into is that because so many people are arguing about the simple basic stuff, like should it be 50 people or should it be 75? What about if it's church or protest? They're arguing about stuff like that. And so the problem is we can't spend any energy then saying, okay, well, maybe we could be more sophisticated about the 7% for a large venue based on what we know the risk factors are. So physical distancing, wearing masks, total prevalence in the population. It makes it hard to put thought into that because everyone's fighting about things that really no one can answer, 25 versus 50. And so we get distracted by all that noise. So I hope that kind of answers it. I mean, my general philosophy is yes, like we need, because we got lazy about masks and because we got lazy about physical distancing, we as a community, we have seen a certain resurgence of COVID. And so just like, when I'm a parent to my kids, like I'll give you as much responsibility as you can handle. And if you show you can't handle it, then we have to be stricter on the rules.
That's great. Well, the questions are beginning to really pile in here. So this next one, I believe you can read it, Dave.
That's because I'm digging into deeper holes here. So
Why do you think people have so drastically lost faith in vaccines? Is it because they don't trust science, this administration, or is it something else?
So it's a good question. I think it's multifactorial. One component is, I think that science is complex, right? And science is never 100% right. That's not the point of science. The point is you create a hypothesis, you test it, you have what is a truth for the moment, and then you evolve. If you didn't evolve, we would still think the world is flat and that we are in the center of the universe. So science is truth based on what facts you understand at the moment. Life has gotten so complex that I think it's hard for people to sometimes think through those problems. And part of what's happened is because the information environment has changed so dramatically that there's no time to think and ponder and sit there and try to figure something out and to say, oh, well, this isn't something I can understand or meant to understand, or this is something. We are just constantly bombarded, mostly through social media and electronic media, with information. And now that information may be inaccurate, has different levels of accuracy or intent, and that makes it hard to sift through to find what the current sort of accepted truth is. Now, I will say again, I work in crisis, I've worked with the special operations community, and what we see is you can do this intentionally, and it's called an information operation. So you can overwhelm a society with information, or a business or a target with information, and basically shut down their ability to communicate or solve problems because they're so focused on trying to understand the information out there. And I will just say that has accelerated in the last 4 years. It's not because of the administration. The administration does use that tool, but it's Facebook and Google and TikTok and whatever else. I mean, these industries feed off their ability to keep you locked into their message. And by doing that, it's making it so you can't think about the other messages. And so specifically the vaccines, and I apologize for the long rambling intro, but like vaccines are not 100% safe. They're not, but they don't cause autism. So if you're having that conversation, what's the conversation? What is the relative risk of a vaccine? Well, there are things that can happen. You can get Guillain-Barré syndrome. You can get, adverse reactions. That happens. But globally, overall, vaccines have dramatically reduced death from infectious diseases across the world. And it's not even close. I mean, it is like every disease that's been wiped out. I mean, 100 years ago, people died of diphtheria and measles and pneumonia. Like, they don't do that now because of vaccines. And so people need to be willing to accept that and just not go into these rabbit holes.
I've got some family members you might need to have a personal conversation with about vaccines.
Well, I mean, look, so when I was active duty, it was 2001. I was responsible for rolling out the first smallpox vaccination program in the Marine Corps in like 20 years or something like that. And I also had to roll out an anthrax vaccination program. And anthrax was thought by some people to be the cause of Gulf War syndrome. And there were 80 PubMed articles on this. And so I had to sit there and figure out, like, is this real or is this not? And so I understand that there is some angst, but the fact is, like, we have to trust our scientists, and you have to trust them. And part of the problem with some of the political leaders in general is that when you attack science, and it has happened on both sides in history, when you attack science for political purposes, you delegitimize the scientific process, and then people don't know what to trust, and so they don't do the right thing, like get vaccines or get their kids vaccinated.
Okay. You had mentioned about the borders, some that were open, some that were closed. And so our next question is in response to, have North Carolina border closures impacted the spread of the virus significantly in border states?
Yeah, so that has closing the North American border closure. I don't know the answer. Probably not. So maybe the answer is probably not. And that's because we have domestic travel. But what is the spinoff of your question is the public health system in the United States is from an operational standpoint based at the county level. So state-owned, county-run, and part of that goes back to states' rights. Part of that goes back to, only local public health people know the local public health problem, and that's fine when you have, like, I don't know, measles outbreak in a school, or maybe even, like, polluted water like you had in Flint, Michigan. But the problem with the pandemic is you need national leadership to be able to coordinate a whole government approach. And North Carolina, like half the people who work in Charlotte probably live in South Carolina. So these, like, man-made borders mean nothing to a virus. These man-made borders between counties mean nothing. And so in the US, I think we just need to fundamentally look at how we can strengthen the coordination between all of the local players as we move forward and redesign how we're going to respond to pandemics in the future.
Okay. I've grouped a couple of these questions together because a lot of people want to know about Thanksgiving. So it's very timely. What's the risk of airplane travel during Thanksgiving? Can we see the grandkids? Do I have to wear masks all the time in the plane and in the taxi? So if you can just respond to that. Yeah.
So the airplane thing, so my job for Team Rubicon is to make sure that we can safely deploy volunteers all over the country for hurricane response, which we've been doing a bunch. So the airplane thing, I've dug into a bit, and here's my take on it. So it's not just airplane travel, right? So it's air travel. So it's the moment you leave your home until the moment you get to wherever you're going. So that means a car ride, which could be your car or Uber or cab. So that affects the risk. Then it's arrival at the airport, where you're either around a bunch of people or it's a ghost town, but probably you're around a bunch of people. So we know that you've just gone inside, which we know is a risk factor. You put yourself around a bunch of people, which we know is a risk factor. Not all of them are going to wear masks, so that's a risk factor. Then you get on a plane. Now the plane piece, the data is still evolving, but in general, plane air circulates through a HEPA filter, which takes viruses out. And it does it about every 6 minutes, between 6 and 10 minutes. So it's between 6 and 10 times an hour. So it recirculates air. So the air is generally pretty good. If you're wearing a mask, you're probably pretty good. If you wipe off the seat and the table and all the close contact areas, you're probably pretty good. The thing you cannot control for necessarily, and let me rephrase that, the thing that you can control for when you buy your airline ticket is, does the airline fill the middle seat? And so if you fly on a plane, wear a mask, wash your hands, there's no middle seat, and then you're not around a bunch of people on either end of it, it's probably a relatively safe thing to do for an individual with no other risk factors. There are a couple of studies. One was like the early one after the pandemic, but it was limited because it took a bunch of people who traveled and weren't wearing masks, and it was before all the stuff had been implemented. But right now the risk is sort of thought to be about 1% to 2%. So I will comfortably send disaster responders to Louisiana to help people respond. I would fly if I had to for something critical. I think that I would not fly, and I do not recommend to my friends and family flying just for the heck of it or for low benefit events. So Thanksgiving, you have to make the call, in terms of travel. The things that tie into this, though, is flying the kids. I mean, Fauci said this, right? Fauci said, my kids want to come, but they said, I love you too much. We're not going to fly to see you because we are around other people. Flying is a risk factor, and you're old. So they told him that's what he talked about. So if your kids are in college or in high school, somewhere else, your grandkids, it's a high risk event to bring them in to see you. And I see Tom Millie are asking about preschool grandkids. Yeah, I mean, like kids carry the disease. So kids are not getting as sick in general, and that's great. They are asymptomatic and mildly symptomatic carriers. And there's a study that said the transmission from kids to adults is lower, but again, I would take that at face value. If I am standing next to a child who is 2 feet tall, and that's my exposure, and they're breathing into my knee, then yeah, they're probably not going to give it to me. But if it's my daughter and I'm hugging her, or she's sitting on my lap watching a movie, or walking up to me while I'm sitting there eating turkey, then she's in my face, and that is a high risk engagement. And so you make the decision. If you think you can have your grandkids there and the event is all outside and everyone's wearing a mask, and you don't have any health problems, you can make that risk calculation. And that's where, again, going to the CDC website will help you, because it'll say, hey, here are the high risk things, the moderate risk and low risk. And you can craft it and say, look, for me, it's worth it because I haven't seen my grandkids in 2 years. It has significant emotional impact on me not to do this. It's worth it for us to do that. Or you can say, let's wait 6 months until the vaccine's out and we'll get together outside somewhere and it's safer.
Well, thank you, because I have grandchildren coming home, so I appreciate the answer to that as well.
Yeah, we're dealing with this right now too. So
yeah,
it's not my grandkid.
This one is really around what's going to happen in the future, and there's a lot of uncertainty of federal strategy as it pertains to COVID-19. Do you expect to see possible changes in the way we're responding to the pandemic post-election? And that's either way it goes.
Yeah. No, so it's a great question. I think that when you think about like a response, right? You have strategy, you have operations, and you have tactics. So the strategy for how to respond to a pandemic has existed for a long time. We had, the most recent one was like 2009. Then there's a flu pandemic response in 2018 or 2019. And so the strategy for a whole government response to a pandemic is there. Then the question becomes like, how do you operationalize and execute it? So I don't think that the strategy changes too much. We know what we need to do. We need more hospital space. We need better treatments. We need a vaccine. We need public health people to messages to be listened to, people wearing masks, physically distancing. We need more contact tracers. And then, if we do that, we can start reopening society slowly and we can get the economy back and kids in school. So like the strategic stuff, I think doesn't change much. And I've heard this discussed between, the Biden plan and the Trump plan, and having friends in the administration who are actually executing this. Like, I think the strategy is sort of there. The execution piece maybe changes a little bit. And then again, the leadership matters, right? And so if your leader takes off their mask and says things like Fauci is a disaster and an idiot, which was just said this week. If you have a government that pulls out funding of the WHO in the middle of the pandemic and then holds rallies and says it's okay not to wear a mask, like that's not strategy. That's not affecting the strategy. That's affecting the operations and the tactics. And I think that that's where it would change between current Trump administration actions and the potential for a Biden-Harris action. I think you would just see compliance with the existing strategy more on the Biden side. But I think all the core components would probably not be very different. And then the last piece is, part of that is also because health systems in the private sector have stepped up to form a lot of these public-private coalitions with local governments to respond. And so there is a whole new level of sort of non-governmental and pseudo-governmental response going on right now, which is great to see.
So Dave, we're about out of time, but I think we've got time for this one last question. And it says, what does crisis management look like to you on a day-to-day basis during the pandemic? I know there's a lot of EOC calls and things like that happening, but how do you assure that you have the most up-to-date information and from the right resources?
Yeah, it's a great question. So I'm actually trying to write a paper on this right now. So we use this framework that comes from the McChrystal Group and the Joint Special Operations Command. There are all kinds of leadership frameworks, but this one is just, again, we try to put simplicity. So we do assess, align, and act. So assess, align, and act. And so what you're kind of talking about right now is the assess. So how do you validate your information inputs? How do you know when you need to stray out to get additional information? And then how do you consolidate it so that you can then align players into the proper action? And so from the assessment side, what I do is I have my trusted sources now. So I have Google alerts on certain topics. Two is, I trust the CDC recommendations. And then we still have too many briefs a day, but our head of infection prevention does briefings every couple of days. So I track with that. And then I rely on my teams, because what we have done, which is, again, a great evolution and innovation and our response is we've gone back to, again, this team of teams concept that came out of the Joint Special Operations Command and said, how do we move faster and decide faster? And so we have pushed out these cross-functional teams that have individual areas of focus, like vulnerable populations or clinical care or HR policy or wellness. They all cross over on topics, but they're also somewhat hyper-focused. And so as they learn things, they're vetting them and then pushing it back to us so that we can make sure it's shared amongst all the different groups. And so you have to have trust in your team. You have to have trust in sources, and then you have to be willing to accept that even trusted sources are sometimes wrong, and even trusted information changes. And that's the nature of science. And if you do that, you can then actually execute in crisis. There are a couple different models. There's something called the SNEVAN framework. It's like KNIEVAN framework. You Google it, you can see the difference between like chaos, complex, complicated, and simple operations. And it just talks about some of the frameworks on how you approach problem solving.
Well, thank you, David. I appreciate. There are a few other questions that maybe we can send them to you and you can just answer them offline, but I'm going to turn it over to LJ at this time. Thank you.
Thank you, Lois.
Thank you so very much, Dave. This was very, very, I can't open my video. Jesse, for some reason, you need to help me with this, but I will speak to you, Dave and Lois. Thank you so very much. This was very enlightening, very informative. We will share this presentation with other councils around the country, and we do have people from around the country participating. We'll share this with universities and schools, and we'll share this with businesses. I think it is very important information as COVID affects us all. As you said, our families, our community, our businesses, our schools. I think this is one of the best presentations that I followed, and I've been on a lot of Zoom calls on many issues, as most of you have been. And we're lucky to have Atrium Health here in Charlotte in our community, and we're lucky to have people like Dr. David Callaway and Louis and everyone else who's working so hard to help us beat this pandemic, this virus, and get back to as normal as possible a life as soon as possible. I would like to underline the things that Dr. Callaway said. Do wear masks, do wash your hands, keep your social distance, or physical distance, and do socially engage as much as you can, because we're all people and we need to be socially engaged with each other. Be healthy and be safe. And with that, I will turn it over to the chairman of the board of the World Affairs Council of Charlotte. But before we do that, let me just share with you the next Thursday at the same time, we have Marta Bracena Coqui. She's the ambassador of Mexico to the U.S. She's a leading diplomat ambassador in Washington, D.C., and I believe she's considered to be one of the leading diplomats in Latin America overall. And we have with us our board chair, who's also for 39 years been the honorary consul of Mexico to North Carolina, Wayne Cooper.
Thank you, LJ. As my colleague always says, I'm the oldest rat in the barn, I think, as far as the consul. But we appreciate it. Dave, thank you very, very much for just an excellent presentation, as always. I'm like everybody, I've really learned a lot today. And as LJ said, next Thursday, we have the ambassador of Mexico. And I got to hear her about 2 weeks ago on a national presentation. She is, number one, an excellent speaker. And number two, she really, really knows trade issues and trade agreements. And I'm really looking forward to it, but I would encourage you to invite your friends to join us. Remember, if you're not a member, please join. You know, it's your memberships and contributions that help LJ and his staff bring on excellent presentations like we heard today. These are just, we've got so many of these coming up here. And again, we'll look forward to seeing you at the very next Thursday for the ambassador. And with that, I will adjourn, LJ, unless you have something else. Okay. Thank you very much, and meeting adjourned.